Perfect. Hi, everyone. Um, Welcome to this learning collaborative titled Supporting Community Mental Health for Elders Living with HIV. If this is your first learning collaborative with us, welcome. I'm JB Del Rosario. I'm the project manager for the Care and Wellbeing Center, and the Care and Wellbeing Center is a regional HIV and aging capacity building program. We cover 14 states across the Western United States, and we really focus on offering interdisciplinary learning for a wide range of service providers that provide care for people aging with HIV. I want to thank all of you for taking the time to attend this training today. I'm really excited to get started, and I just want to take a moment to first launch some polls here to understand like who's here with us. So there is a poll coming up right now. So what kind of service organization do you work with? Is it an HIV/AIDS service organization, Asian service organization, or another type? And if it's another type, please drop it into the chat, just so we can understand like kind of like who is here and like who our audience is and what kind of expertise we all bring. I'll give about like a minute for us to answer this question as people stroll in, get situated to the space. And also, if you want to drop in the chat your name, your organization, and your role as well, please feel free to do so. So I'll give it a few more seconds on this one. Looks like there's some more people joining, so we'll give a little bit more time for this poll. So the current poll is what kind of service organization do you work with? Is it an HIV/AIDS service organization, an aging service organization, or another type of service organization? And like describe it the best as you can in the chat. And as people are logging on, if you could please drop your name, your organization, and your role. My name is JB Del Rosario. I'm the project manager here at the Care and Wellbeing Center. And thank you all for taking a moment to join us today to learn more about mental health and better ways to support the mental health of our older adults living with HIV. I'm going to go ahead and close off this poll now. And it looks like we have a great majority of people representing HIV/AIDS service organizations. And then I also see in chat that we have a number of different kinds of service organizations as well. So again, thank you for taking the time to join us today as we all have a role in improving services for older adults who are living with HIV. And then we have a second poll here. Which of the choices below best describes your role? Would you say you're a medical service provider, a social/supportive service provider, or another type of service provider? Oh, sorry, that says service organization, but which choice below best describes your role? Because we really try to create our learning opportunities for a wide range of audiences, so we can best tailor how we go about this presentation, so everyone takes something away with them around the mental health for older adults living with HIV. I'm seeing a number of people join as well. We're doing a couple polls, and to better understand our audience today, and thank you for taking the time to join us to learn more about the mental health considerations for older adults living with HIV. I'm going to give this a couple more seconds before I end it off and share the results. I'm seeing some familiar faces here and some new faces. So thank you everyone for joining. If this is your first learning collaborative, I'm excited for you to join, and thank you for taking the time. If you're returning, great to see you. I see a couple of familiar faces. Hope you all are doing well. Um, and to end this off, it looks like we have a good split among with the majority being social and supportive services, and some medical service providers, and then other types of service providers as well. So thanks y'all for taking the time to complete those polls. Looks like we have a great audience here. And these are going to be our learning objectives for this session. We really hope that you gain a foundational understanding of the different factors affecting older adults living with HIV, using the expertise that is going to be shared by our great speakers. And I would like to have a land acknowledgement for the Remitters people. UCSF operates on their land, and we hope to take this information that we're sharing today and the energy that we're also developing through our different partnerships to honor the past, present, and future stewards of this land, and wherever you may call home, and wherever you may serve your clients. And I want to take a moment to introduce our great speakers today. We have three different groups to help us better understand the mental health considerations for people aging with HIV, starting with the Department of Psychiatry over at UW, over at the University of Washington, the Health Promotion and Research Center, also at the University of Washington, and Neighborhood House. So I'm gonna pass it off to one of our great collaborators, James Lee, to introduce himself and start us off.
Huzzah! Good morning, everyone. My name is James Lee. My pronouns are he, they. I am currently one of the chief residents here in the Department of Psychiatry here at the University of Washington. So hello from Seattle. The weather is a little cloudy. I'm just excited to be able to collaborate with Drs. Bespalova and Jackson as well, who are also here. They have been fantastic mentors, and we have compiled some slides, hopefully kind of getting at the idea of like, what is psychiatry, let's start there, right? And then kind of thinking about how psychiatry interacts with the whole field of medicine, on top of thinking about how specifically HIV and aging interact with our field as well. And our hope is that we can give you some kind of concrete points and some concrete takeaways that you can take away into your own practice, which will be lovely. Let's get started. Let's get down to the basics, right? So what in the world is psychiatry? It's the branch of medicine focused on diagnosis, treatment, and prevention of mental, emotional, and behavioral disorders. So psychiatrists are, let's just get things straight. Like, psychiatrists go to medical school. They train for 4 years in a medical school and then do residency on top of that to kind of hone the field of psychiatry. Psychiatry is often confused with a lot of other specialties like psychology. So we'll kind of get into that a little bit later. But psychiatrists are typically associated with kind of prescribing medications and giving mental health diagnoses. So what's the difference between psychiatry and psychology? We're both trained to identify and treat mental health conditions. So as psychiatry, you're thinking medicine, right? So psychiatrists are typically the people that are prescribing antidepressants, antipsychotics, and kind of doing the prescription part of things. And psychologists typically go to graduate school. They get a doctorate in psychology. You might see like a PhD after their name or a PsyD after their name, but psychologists more kind of go to learn about psychology, and they're typically more associated with doing more therapy. Therapy is this pretty general term. A lot of people can do therapy. A lot of amazing therapists come from a wide variety of backgrounds, including social workers, psychologists, and psychiatrists. We have some amazing nurse practitioners that also gives great therapy. So therapy is a pretty general term. A therapist can come from a lot of different kinds of specialties. But that is kind of a good difference between a psychiatrist and a psychologist and a therapist, and just kind of gives you a little bit of a Venn diagram of all of those disciplines. And we often work together. Working together is important. Psychiatrists tend to treat a wide variety of disorders. The most common ones that we see and that we'll kind of narrow in on during this discussion is thinking like depression and mood disorders, but we also work with a lot of people with schizophrenia and chronic psychosis. Substance use and addiction is a huge part of our work and continues to grow to be a large part of our work as well. So what does psych treatment look like? Typically what happens is when we are referred a patient or a client, we do a whole evaluation, we do a whole history. We sometimes get laboratory testing to see if there are medical causes for patient symptoms. And we really want to emphasize that, yes, just because you see a psychiatrist does not mean that you necessarily are going to be recommended a medication. A lot of times we actually don't we don't recommend a medication. We often recommend behavioral techniques or other techniques that we think that may be a better fit for clients. When we prescribe a medication, it's important that we consider all the effects of the medication. So will it work? I always say that my cardinal rule for prescribing medications, it has to do two things. It has to work. Let's start there. And it also cannot have unacceptable side effects. So those are the kind of like the two main kind of cruxes of like, yeah, whether or not we prescribe a medication and whether a medication, we continue a medication going forward. We oftentimes do refer patients to psychotherapy, whether that's within our own practices, but more frequently, especially within a large academic setting like ours, we typically have therapists that are affiliated with our clinics that we can refer to as well. I think there's a really important component of thinking about what psychiatry has done in the past and the history of psychiatry, thinking about specifically how homosexuality used to be a DSM diagnosis, which means that it was like kind of perceived as a mental illness. And medicine, it has been a system, and our goal is to try to arc things towards justice, right? But psychiatry, alongside a lot of medicine and alongside a lot of power structures within this country, have perpetuated a systemic inequality and systemic injustice. And our goal as current providers is to right that wrong and to try to see where the systems have failed our patients and our clients currently and how we can move forward with that. Understandably, and we're going to go a little bit into this as well during this discussion of HIV and aging, but a lot of our clients don't trust the medical system because of prior injuries or because of bad provider interactions. And that's so understandable. And our goal is to, once again, to try to kind of right those wrongs and try to figure out, hey, where are ways that we can really give back to those communities so that we can, start building more trust again. And I'm sure that that is something that y'all already do in a lot of your work. And we're just going to hopefully kind of continue to add to that toolbox. Common myths. I'm going to be forced or coerced to take a medication I don't want to take. Psychiatry, like a lot of forms of medicine, is collaborative. There are a few cases where we may disagree and there's large acute safety issues. But in the grand scheme of things, psychiatry is very collaborative, and we really want to make sure that people, when we prescribe a medication, that people will take it and that it's helpful. And if it's not helpful, that they can stop it. I'll be prescribed a bunch of medications. Like I said, oftentimes psychiatrists don't prescribe medications. We sometimes prescribe behavioral techniques or seeing therapists as opposed to taking a whole bunch of meds. Psychiatrists can also give therapy, which is important. And yeah, like I'm going to be given medications that will change me as a person or change my soul or make me a zombie. And that, like I said, those are, one could argue, unacceptable side effects. So then we try to have this collaborative discussion, right, about what a medication is and how we can best be helpful. If I mention suicidal thoughts to a psychiatrist, I'll be hospitalized against my will. This is a super tricky one. As a general rule, there's no kind of code that we follow, like, you mentioned suicide, it's time to go to the hospital. That is definitely not what originally happens. What we typically do is we ask more questions. We get to know the situation. There may be times where we do recommend a hospital stay because we're really concerned about safety. But a lot of times we try to strategize with clients. We try to be like, hey, like, what can we do to be helpful? Can we get a safety plan going? What's your risk now? Do you want to come into the hospital? So there's a huge discussion that happens. And oftentimes we as psychiatrists really want people to be able to feel comfortable to talk to us about suicidal thoughts, because that's a huge thing, right? And that will be hospitalized against my will. Once again, yeah, we try to make a collaborative discussion. There is a chance of involuntary hospitalization. I don't want to minimize that as a potential risk that might happen. But also we really want to create a collaborative environment where we can work together to make sure that people feel better and they're behaving okay and that they feel okay moving forward. This is going to be, I hope this is helpful just in terms of thinking about when to refer people to psychiatry, when you're not sure about a mental health diagnosis, when you are prescribed a medication and it doesn't feel like it's working, or you feel like the medication has a lot of side effects that are unpleasant. Referring to psychiatry is we've gotten referrals for a lot of different things in the past, and that is very okay. And our goal is to, once again, to work with not only the patients, but also with you as people who refer us, and we're going to collaborate together. Psychiatry is very collaborative. If you hear that word a lot of times today, it's because I thoroughly believe it. Psychiatry is a very collaborative field. Great. So that's kind of like a broad update of like how we think about psychiatry as a field. I do want to take just a step back and think about, when we think about HIV, and just give a little bit of history about how this epidemic has changed people and what a lot of our patients who we're going to talk about today have experienced. So just thinking about zooming back to 1981, it's kind of the first kind of starting to discuss what HIV was. So the term gay cancer kind of entered the lexicon in July 1981, specifically within San Francisco. And like a lot of illnesses kind of surrounding chronic immunosuppression, like pneumocystis pneumonia, started to become publicized. 5 years later, AIDS cases continued to progress, and then a lot of people died. 51% and 51% of adults and 59% of children end up dead after being diagnosed with AIDS. I want you to note the large time difference between 1981, which is when HIV/AIDS became kind of sort of entering the lexicon of people's daily lives. And then 6 years later, that is when President Reagan actually started to acknowledge AIDS for the first time. So there's this huge gap. There's a 6-year gap when the government truly was staying out of things. And there was a lot of panic and a lot of people were dying, and it felt like the government was not helping the people that needed help. In October 1987, a lot of, there was this, frankly, there's this kind of homophobic amendment that kind of discussed like HIV in the setting of homosexuality, and that educational material could not promote homosexuality. Whatever the heck that means, right? But it kind of continued this rather homophobic narrative that went alongside the HIV epidemic. 2 years later, in 1989, the AIDS cases in the US breaks 100,000, which is a lot of people. In 94, AIDS becomes the leading cause of death in America in ages 25 to 44. 95, AIDS cases hits 500,000. So as we've seen with as we saw with COVID in a lot of ways, right? Like it spreads fast, and those numbers really exponentially went up. In 98, that's when we kind of started to see the beginnings of antiretroviral therapy, which are the medications that are used to treat HIV now. And yes, a lot of time has elapsed in that time. I think it's important to give context. A man who was 21 when HIV was first realized is now 63 years old in the year 2023. So a lot of time has passed, and a lot of relationships with HIV have changed. But it's, I think, important to remember, what it was like when it first started. Depression and HIV is a very specific relationship that I think is very notable that we want to discuss. When you hear depression, I think there's a lot of colloquial for like, I'm depressed, I'm sad. When psychiatrists and a lot of people in mental health use depression, we typically are referring to major depressive order, which is a very specific kind of diagnosis that's given. A lot of people have MDD, and we kind of think of disruptions in, as you see this mnemonic of the SIGI caps, like sleep, interest, guilt, etc. And depression and HIV have this really close relationship in a lot of ways. Depression is the most common neuropsych complication in HIV, and there's a lot of, and you can kind of see the cyclical nature of it. Depression can worse, it can increase the risk for HIV because it can increase HIV risk behaviors. It can cause increased in unprotected sex or substance use. And then HIV can worsen depression, given the stigma, given kind of the neurobiological effects of things and the side effects of the medications that we prescribe. A tool that we want to that we think a lot of people can use is kind of thinking about depression screening. So whether this is a form that people fill out when they come visit you, or whether this is a question, these are questions that you can just integrate into when you meet someone for the first time. But there's the frequent ones that we see are the PHQ-9. That's the one that you see in a lot of doctors' offices today. And then the one that you actually see on the slide is called the Geriatric Depression Scale, also called the GDS. And you can kind of read some of the questions. We won't dwell here too long, but this is a screener that is used to assess, how are people feeling depressed, and are people at risk of meeting criteria for MDD, and would it be helpful to connect them with a doctor, who, whether that's their primary care doctor or a psychiatrist, who can kind of nuance those medications a little bit more. Kind of thinking macroscopically now, we want to think about the barriers impacting aging with HIV specifically. So there's these psychosocial ones. Ooh, we're just gonna clickety click through all these. Lovely. So thinking about psychosocially specifically, there's adverse mental health outcomes, increased social isolation in patients who live with HIV, and quality of life often decreases as well. There's a lot of shame and loneliness, and that can accompany an HIV diagnosis. Stigma as well. We want to think about the physical components of thinking about HIV and aging. So there's greater physiologic stress. A lot of people report fatigue. When you see the appearance, those with visible lipodystrophy, so people who kind of have who like lose fat in certain parts of their like face and their body, had larger effects on their quality of life. And you just like, there's something like visible about the HIV diagnosis that people have noticed as well. And we also think about systemically, there's marginalization of people of color, and just thinking about the intersectionality of how HIV and age also intersects with other demographics like sexual orientation, and race and gender, et cetera, et cetera. They all kind of, there's a lot of discussion about how these different factors come together and how they impact lives in pretty significant ways. The concept of a syndemic, this is kind of, a syndemic is when we think about two or more disease processes kind of coming together. So when we think about aging and HIV as separate processes, they obviously have their own specific kind of clinical symptoms and things like that, but they can oftentimes work synergistically and kind of cause more distress or more challenges. So we think about aging with HIV as a syndemic. HIV positive patients, I'm going to just put these facts up real quick. As a general rule, we see that the PWH is people with HIV. HIV positive patients have higher rates of depression, poorer cognitive functioning, and rates of depression tend to increase in older HIV positive individuals. And yeah, there's more likely to be socially isolated compared to HIV native peers and younger people with HIV. Someone is coughing, and I just want to let them know that they are coughing on not on mute, and that is okay. But just I hope that you feel better. And yeah, thinking specifically about social isolation, and how HIV has been an isolating factor for a lot of different people, especially during the COVID-19 pandemic, which you can see the slide here. I want to be really respectful of our time. So there are large frameworks that I will kind of gloss over really quickly, but we do have kind of our references here in the final slide. But thinking about minority stress processing, so thinking about how people with a minority status, whether that's HIV, whether that's queer, whether that's a person of color, have multiple different stressors that kind of affect them. So there's the concept of distal minority stresses. So that's things that are outside of people's control, kind of further away. So that's prejudice events, that's discrimination, that's violence. So kind of external factors. And then there's proximal minority stressors, which is the concept of like internalized homophobia is kind of a big one, or expectations of rejection. And all of these things kind of interplay with each other. And then there's this other factor of resiliency and thinking about people being resilient and coping and having social support to rely on. And all of these things together kind of jumble together and cause mental health outcomes, whether they are positive or negative. You can see in this lovely diagram that is made by the amazing Sam Jackson, that there are kind of different ways to then react to a stressor. So you can see that at the very top, the green light is the resilient reintegration, or also called post-traumatic growth. This is when people who undergo a traumatic incident are able to rebound and really kind of find a lot of growth find a lot of like personal growth and are able to grow from that experience. There's this concept of under that, which is still a green light because it's still good, but reintegration to baseline. So after a traumatic incident, this concept of, coming back to where you were before. Reintegration with loss is a yellow light. It's a balance. Sometimes you're able to reintegrate, but you just aren't able to integrate. You still have losses in a lot of ways, and that's tricky. And then what we oftentimes see in psychiatry is dysfunctional reintegration, which is when people try to reintegrate after a traumatic event and they just can't. And they have depression, they have anxiety, they have a lot of stressors and frustration. This is all a way that we kind of cope with different stressors, and different minority statuses, and HIV specifically can put us at higher risk for dysfunctional reintegration as opposed to reintegration to baseline. This is just a really powerful picture of the San Francisco Gay Men's Chorus. This was in May 1993. The people wearing black are the people, is just representative of like all the people who died from HIV. The people who were white were the survivors. So just a really powerful visual image of what living in that decade was like, and what that was like to kind of survive and see loved ones around you not make it. And that all affects kind of how we are able to reintegrate into the lives around and into the world around us. These are, I think, just important statistics. I think that they really showcase the hardship of what it was like to live with HIV in that time. 1 in 9 gay men were HIV positive in 1996. 1 in 15 had died. There's this really important kind of context of just thinking subjectively about our clients. The line at the very end, I think, is very poignant of like, if you don't know when you're going to die, what's the point in saving money or for the future or making plans? You just live for the moment and try to cope. And I think that is what caused a lot of people to like, engage in maybe more substance use or make like harder financial decisions that if they survived, then made things harder for them to continue. So we think about, the generational trauma aspect of things. Perhaps our next problem is not going to be coping with death, but rather coping with the rest of our lives, which is a really real thing. We are thinking a lot about how AIDS has changed a lot of people's experiences, whether it's the queer experience, whether it's, and also the not queer experience, but AIDS has now become a more manageable illness. There are medications work for a lot of folks, and it keeps HIV, and it keeps like the transmission and also the fatality of HIV down. And yet we still have a lot of people who grew up with HIV in the 80s and 90s who are still really traumatized from this. So there's some dissonance as they move forward, and they're like, wow, my AIDS experience is so different from the ones of people who are younger than me, who are growing up in this generation. So there's just a huge kind of disparity there, and I think that we as providers need to be cognizant of that and understand that maybe our own experiences of HIV are very different compared to those of those who are in their 60s or 70s. We think a lot about resilience, and I know I'm running out of time, so I'll just wrap this up really quickly. But there are a lot of people. HIV is clearly not only I mean, HIV was a terrible thing that that really swept through the country and was very bad for a lot of people. But it also showcased the beauty of kind of personal resilience and also a lot of community that was built throughout these last 4 decades. We think about resiliency factors, so like social connectivity, generativity, self-acceptance. So these are general themes that a lot of people who are resilient have access to. And we do see quite a bit of resilience over time as well. Post-traumatic growth is this concept of, how do we really lead to a change in our functioning or development after a trauma? And how do we integrate traumatic experiences and try to grow from them? And that's a really hard thing. And we see a lot of that within populations as well, but it's just something to kind of consider as we move forward. In one study, post-traumatic growth was associated with higher ART adherence, lower alcohol consumption, healthier dietary habits. So these terms really do have, they really illustrate something about people's ability to move forward in their lives with HIV and AIDS. So I hope that this gives you a little bit of linguistics of how do we view the people in front of us and what their trajectory can be. Putting it all together, just thinking about, HIV is a risk factor for depression and other mental health conditions. And it has changed a lot. The narrative surrounding HIV has changed a lot. There are many screening tools. I've given you 2, which are the PHQ-9 and the geriatric depression depression screener. And those can be done by mental health providers, but they can also be done by everyone, and it can help give a little bit of guidance of what next steps could be. And psychiatrists are here, and we can treat mental health and substance use disorders. We don't just use medications. We, like I said, psychiatry is super, super collaborative, and our goal is to work together with everyone to make sure that we can come up with the best outcomes. And yes, go team. And these are our references. And on that note, I think I will pass it back to maybe JB or Leslie for the next steps.
I'll take it from here. Thank you, James. Truly appreciate the time you all took to put together this presentation. Really appreciate the collaborative focus of the presentation as well, and just sharing with all of us how everyone has a role in assessing, referring, providing information, or just being an open ear for older adults living with HIV. And how we don't have to be specialized in order to engage in mental health conversations and provide mental health care. And how we can all work together and to best assess the needs and serve the needs of our clients. I want to take a second to open up the space for discussion. If anyone has any questions for our awesome presenters here, please feel free to raise your Zoom hand or get off mute. They have a wide range of knowledge between the 3 of them. So opening up the space to receive any questions regarding psychiatry, regarding the presentation itself. We do have a couple minutes for this before we can move on into the next segment. Let's see. Robert, you have your hand raised. Go ahead.
Hi there. One thing that I was thinking about as I was listening is that unfortunately, history is repeating itself in many ways right now. And as you know, I'm in this generation that was just talked about, and in this group of people that was talked about and went through a lot of these things. And I think as many people, felt that we were making continual progress in many ways towards acceptance, toward not only acceptance, but just being full members of our culture and our society. And now in many places, as we know, politically, it feels like we're back to another time. And I wonder what, I work at the California Prevention Training Center. I work with, sexual health clinics around our Western region. And so and I worked in San Francisco for many, many years. So I feel like I'm kind of in a bubble when we talk about these political matters. Like I could write emails and letters to Nancy Pelosi all day long, but it doesn't really make a difference because she always votes the way I want her to vote. Right. So I wonder, I guess my question is, what can we put into practice of what we've learned to try to really prove that we have made progress, and that for younger queer people, especially right now, young trans and gender diverse people, what can we do to sort of, I guess, in one way, fight back against all of this stuff that's going on, but also to let everyone know, especially young people, who I think in many ways coming out is not any easier for some young people than it was when I came out, however many years ago. Anyway, that was kind of long-winded, but there is a question mark at the end of that.
Yeah, and I think honestly, like I can take that for a bit. Other speakers as well, or anyone else in the audience can also provide their input. But the question I got is like how can we show the progress, and what can we share like with this upcoming generation? And it's really striking that you bring up this conversation as well, because we just convened our community advisory board for the Care and Wellbeing Center, and they had the same exact question. People that lived through the early days of the epidemic and experienced the entire thing up until today. So I think one of the pieces of progress for us to share is there is a lot of legislation happening here in California and throughout the different states to include older adults living with HIV as a protected class of people to prioritize for services. In California, that's SB 258, and there are a lot more states that are developing their own kinds of legislation similar to it. One resource to help guide people to is SAGE. I forget what the acronym is, but SAGE USA, they have a couple of resources on specific language to use when you're advocating for these system level changes for like LGBTQ older adults, people or older adults living with HIV, and different key priority populations as well. And then they're based in New York. The West Coast version is Open House here in SF. So I appreciate your question on like how can we show the progress and how can we keep this work going? Because like now that we are entering this age of this shifting focus of the epidemic to cater to people who are aging, we're really going to have to be creative in like who we pull in and how we identify our collaborators and like work together. So hopefully that answers your question.
I think I can just take like the other half of the question I think I heard is just like, how do we like help the people in front of us, right? Because I think that it's good to know that we have a lot of resources and like there's a lot of legislation, there's a lot of movement forward, and there is progress still that is being made, and that there are lots of people that are fighting. But I think that the other half of that question is like, how do we also like sit in that grief of like, yeah, regardless of all this progress, like there are still multiple queer people that are dying, not only in the United States, but also in other countries. And like in a lot of ways, it still doesn't feel safe to be queer in this country in a lot of ways, or doesn't feel safe to live with HIV in this country, or to be old in this country. Like it's hard to feel that safety. And a lot of that work that I personally do is within psychotherapy. So that's when I'm like working with people individually, and I'm just like sitting in that grief and also trying to kind of figure out like, yeah, like where is that coming from? Like what are ways that feel actionable and what are ways that don't feel actionable? And like, how do we, I think that at the end of the day, this is a story about community and trying to connect with people around us from similar and different life experiences. And I feel like, yeah, like therapy or like setting like not only therapy, but like creating expectations of like, yeah, like let's build community together and be next to the people that we love and cherish. Like that feels really important. And I feel like we forget that. That's a really important component of like who we are as people and how we should move forward. So I kind of heard a little bit of just like, yeah, like what can we do to reassure people? And I think that a lot of what we do is not necessarily reassure people, but also being able to just like acknowledge that things are hard. And when we hear news that is hard, we can sit there too and grieve, and then also figure out, yeah, what are the next steps?
Thank you. Thank you for the question. And Sean, see your hand raised. Feel free.
Okay, thank you. I just wanted to speak to the man, and I forget your name, I'm sorry, that was from San Francisco and writing letters to Pelosi. I did a lot of work in San Francisco. I lived there since 1990, but then have moved to Mariposa County, which is just outside of Yosemite, which they, the region they lovingly call Calabama, which is a completely different bubble than my adult formative years in the San Francisco bubble. And I just want to make sure that people are cognizant of California is very varied once you step away from the coast. And, going to conferences and going to webinars like this, it's very metropolitan centric. And all these, hardships are even harder out here in the middle of nowhere. And in the parts of California that are redder than you can even imagine. So I just want to kind of bring that to the forefront in talking about trauma and talking about experiences. When you step out of San Francisco or LA or even Sacramento, it's a different world here in Mariposa County and the like. I was just at the 50 plus conference in Sacramento, and the kind of strategies put forth are great, and like other strategies that I learned in San Francisco just don't apply here. You can't make them work here. Outreach is different here. All things are different here, like getting congregate housing or assisted living for 50 plus people in a place where there's 12 people living with HIV in this county. At this point, I've gone up to 20. So it varies, and trying to get the assistance and the help in places like this is extremely hard. So I just wanted to kind of put that out there, and have people start thinking differently from metropolitan areas, because that's where the people are going to be lost, is in the far-flung places. So thank you. It was more of a comment than a question, but thank you.
And yeah, that's where our technical assistance also comes in, so we can better curate these learning opportunities and these different resources to the different localities in which we live and work. And John, I see your hand up, but we're going to have to save your question for the Q&A section later. I just want to move these segments along. So thank you for your patience. Feel free to drop in the chat as well for our presenters to address. But with that, I would like to pass it over to Leslie Steinman and Bradley Carlos, up also in Washington. So welcome, and I appreciate you taking the time, and excited to hear more about the Pearls program and share it with this audience.
Great, thank you. Thanks for inviting us, JB and your center, and also James for your really thoughtful presentation. So Bradley and I are going to be sharing a little bit about one community-based model for late life depression and isolation that we think may support the work you all are doing in the Learning Collaborative to support people aging with HIV. Next slide, please. So a little bit about where we're from. I'm from a CDC-funded prevention research center up in the Seattle, Washington area. We work all over the country, though. And it's really about integrating evidence-based and community-based care to improve lives. So evidence-based, is a term thrown around a lot. It means something that's been developed using different research and evaluation tools to look at outcomes and show it works. But community-based is what really matters, right? Where do we put these programs where people live, work, pray, play, and age? I do want to call out, increasingly we focused on more health disparities, health equity issues, so trying to reach some of the populations who've been systemically excluded from care. And we do a lot of work around not just developing programs, but getting them into different settings. So I really appreciate the comment just now, Sean, talking about rural areas and just the different realities around resources. So partnering in settings to make sure that we develop programs that folks have access to. Next slide, please.
Hey everyone, my name is Bradley Carlos. I am the Community Resources Manager here at Neighborhood House. Just a little bit about Neighborhood House. Neighborhood House is one of the oldest human services agencies in the Seattle area. Today we continue to provide services to address the needs of entire families with a focus on low-income community members, public housing residents, immigrants, and refugees. We serve thousands of people annually in King County through our major program areas of early childhood education, youth development, employment, adult education, housing stability, and community health. I actually belong in the community health department, where we focus on case management, resource navigation, support groups, and health and wellness. Or health and wellness programs, and Pearls being one of the programs being offered. Next slide, please.
Thanks, Bradley. So really the lens that Bradley and I bring to this work is we are community academic partners on Pearls research and practice. So I sit at a research center, Bradley sits out in the community organization, but we do research. We also coach folks, we train people to do Pearls. Bradley provides care coordination and manages this work. And really the population we primarily work with are older adults living with depression who've been underserved by clinical care. So I really appreciated James destigmatizing and normalizing and talking about the collaboration within psychiatry and clinical care. We're going to be talking about the care that happens, outside the clinic walls in homes and communities. And the people we primarily work with Pearls are people who are experiencing poverty, have really complex health and social needs, and face a lot of stigma. So I think touches a lot on the presentation James gave in terms of the realities of folks aging with HIV. And we partner a lot with home and community-based services like are on today's call, from social service, mental health, and public health spaces, and really trying to empower lay health providers to do mental health care. Next slide, please. So I want to talk a little bit about where Pearls came from and why this model was developed. Next slide. So we know, and as James touched on in his presentation, the issue is that older adults face inequities in depression burden. So it's less about having higher prevalence and really more about having worse access to care, though we know that depending on your social identities, that people have higher risk. So depression is a leading cause of disability. It impacts quality of life, function, health, and really preventable deaths, particularly when we look at people aging with HIV and older adults. It's a leading risk factor for suicide. On average, depression, about 1 in 5 older adults are living with depression, but we know this is higher for marginalized elders. When you look at the rates for people aging with HIV, they vary anywhere from 40 to 75%. So this is a huge issue. And sadly, despite the fact that there's lots of interventions at work, only about 1 in 10 people are receiving adequate care. So this would never fly, I think, for physical health conditions. So this also shows some of the inequities around mental health compared to physical health. And we know that HIV stigma and ageism and homophobia and some of the inequities that James was referring to really create a greater risk of depression among older adults living with HIV. Next slide, please. So the idea behind Pearls really aligns with recommendations around how do we close the mental health treatment gap for older adults as we embed care in community-based organizations that have trust and rapport with those folks. So how do we build capacity among trusted home and community providers to do mental health care? This really aligns with older adults' care preferences who may not want to do therapy in a clinical setting or receive a medication, though those are great solutions if that works for folks. It's trying to remove some of those barriers to care, whether those be physical around mobility and transportation, cultural around kind of who should be providing care and even talking about depression, and some of those financial barriers in terms of just not having great mental health parity. The idea of PEARLS and other community-based models is that you shift or share tasks. I think JB highlighted this too. You shift or share tasks out into community-based providers and really build their capacity to do screening and provide brief interventions, and then link to clinical care as needed to provide some of that additional support that James alluded to. And then social service providers and community-based organizations also have this amazing opportunity to address some of these upstream drivers of mental health burden. So these are things like lack of access to safe and affordable housing, healthy food, living in an environment where there's a lot of discrimination. So social service, I think providers can also address some of those social aspects of mental health in addition to some of the symptoms. Next slide, please. So PEARLS really was born up here in the Seattle-King County area. It's an acronym, stands for the Program to Encourage Active and Rewarding Lives. And it was really co-created with social service agencies you see here on the right. So these organizations came to us at a center and said, look, we're seeing a lot of depression burden in the aging community, and we need a solution that we can do. So when we refer, folks don't have access. So we want to train our case managers, our social workers, folks who don't have mental health clinical training to do brief interventions for mental health care. So it's really was trying to remove some of those barriers I talked about around access to care, addressing some of those social drivers of mental health, and then aligning with those care preferences as well. Next slide, please. So I'm going to talk a little bit about what the model is and where it came from. So the next slide shows several integrated care or collaborative care models that PEARLS is based on. So on the left here, you see the chronic care model, which was developed up here in Washington in the 80s by Ed Wagner and his colleagues. And the chronic care model really tried to look at getting care. The health system is beyond those clinic walls because people spend about 99% of their time right outside of a health system. It also tried to improve chronic care within the health system. But here you can really see community embedded next to the health system. And then what's really essential to PEARLS and other models like PEARLS is really how do you empower and activate and inform people living with the chronic condition to manage their care. So kind of a self-management approach. And really we're thinking of HIV, given the history that James was sharing, is really living with HIV and aging with HIV now as like living with other chronic conditions, right? On the right-hand side, you see the collaborative care model that was developed by Dr. Jürgen Unitzer and his colleagues here at the Department of Psychiatry at the University of Washington. And in the center, you can see that BH or behavioral health care manager. And that's the key kind of ingredient to this model, right? Who do you train within a setting to provide screening for depression, to provide care coordination, to provide brief behavioral interventions, and then link to someone like James, a psychiatrist as needed for support. Because the idea is that while psychiatrists and psychologists are fabulous at treating mental health conditions, there are many fewer of them, and particularly in areas that are rural or more under-resourced, it's very hard to get access to specialty mental health care. So how do we build capacity within social service agencies and other community providers to be care managers, and then link to clinical care as needed, both for depression treatment, but also management of HIV and other chronic conditions. Next slide, please. So this is the model of care. It's about doing screening. Depression is really historically under-recognized among older adults because of stigma, people thinking it's a normal part of aging, people thinking it's a symptom of a chronic disease. So we use the short version of the PHQ-9 that James talked about. The first two questions are the PHQ-2, and it's how do you kind of embed screening what you're already doing? If folks are calling to get access to food or calling an information or referral line, calling to get connected, how do you make sure you're screening for depression and isolation? It's about measuring outcomes. So we use the PHQ-9 to both teach what depression is and isn't for people, but also to track people's care over time, because that allows you to make sure people are getting better, and if not, linking to other care as needed. The core of Pearls is really that trained care manager that I talked about, training some of your organization to, provide that screening, track outcomes, but really teach 2 tools to help people manage their depression. I'm going to talk about those tools next. It's about collaboration too, and being part of a team. So how does the care manager or Pearls coach or counselor work with the older adult and their community, work with their supervisor, who's the clinical supervisor for the program, which can be a psychiatrist, psychiatric nurse practitioner, someone with some of that medical background. And then how do we put care in an accessible setting? So it traditionally was offered in the home because that's where people are most comfortable. It allows you to kind of see their whole environment. But we've also done really Pearls wherever folks can access, on the phone, on Zoom, out at the community where people are already coming to gather and socialize. Next slide, please. So more kind of nuts and bolts about the program. It's really meant to be done by whoever you have at your agency. It's not about hiring new people and spending a lot of funding. We also build in a clinical supervision model, so that's some of that kind of task shifting sharing I talked about. So that clinical supervisor doesn't actually see clients, but they're there to support your Pearls coach. So if somebody is suicidal or develops some type of complication with a medical issue, they're there to provide really kind of that continuum and coordinated care. Pearls is really meant to be for the people you're already serving. It's not required that anybody has a depression diagnosis. We use that PHQ-9 tool to see whether someone has clinically significant depression and might benefit from the program. As I mentioned, it happens where people are. It's all about access and removing some of those barriers to accessing care. And it's meant to be brief. It's meant to be 6 to 8 sessions that are done one-on-one over the course of about a 4 to 5 month period. And we try to taper them from weekly to monthly so people have an opportunity to build trust, build skills, build rapport, and then kind of practice and integrate those skills into their life going forward. Next slide, please. So I mentioned that the Pearls coach or care manager or counselor, it's really up to you what word works for you, deliver 2 tools that are really brief and structured and person-centered behavioral interventions to help manage depression. So the first is called problem-solving treatment, or PST. And the idea here is that older adult symptoms are caused by everyday problems that pile up. And so when we think of people aging with HIV and the stigma and the isolation, the disconnect, maybe the side effect from those medications that James talked about, those can become overwhelming and create depressive symptoms. Some problems, not all, right? This is not a panacea, can be addressed by using these 7 steps to problem solving, which I'll talk about in the next few slides. And the idea is that by gaining this sense of control over your life that feels overwhelming, you can be empowered to actually feel better mood, feel more energy. So that's problem solving, and I'll go into a little detail in future slides. Behavioral activation is the other tool that we teach. And the idea with behavioral activation is when we feel bad, we stop doing things we enjoy. And so how do we intentionally and thoughtfully plan more pleasant social and physical activities to feel better? So instead of waiting to feel better, how do we plan those as a way to build back mood boosters into our lives? And what's really important here is that, again, the person-centered piece, these are activities that are meaningful and accessible to the people you're working with, rather than what often happens in some care provision, right, where it's kind of, oh, you should do this, right? So it's trying to help people identify things they can do in their lives. Next slide, please. So I want to talk a little bit about kind of why the problem-solving treatment and the rationale for that and some of the steps. And so this actually slide fits really similar. I really loved your slide, actually, James, where you talked about kind of the systemic and the physical and the psychological kind of risk factors for depression. So this is quite similar, right? So people living with HIV and aging with HIV may have low self-esteem or negative thoughts or stigma. They may have stressors related to the management of HIV, some physical issues around living with HIV in terms of affecting their sleep or their energy or their pain. And then that can impact some behaviors like withdrawing from activities they might have used to enjoy and felt connected. And so all of these create this cycle that contributes to depression. Next slide. So problem-solving treatment is a way to basically teach people how to break that cycle. So as I mentioned in the previous slide, it's not a panacea. It's not going to solve all problems, but just starting to feel like some things are getting better can help people feel less depressed. This is meant to be super brief and structured, very much focused on the here and now. So there is some kind of stigma or resistance to some therapy for older adults who really like don't want to go into the past problems. Maybe they'll get there, but they're not at that space yet. And so this really helps kind of like what's happening in my life now. And even the previous discussion talking about the the reality of the lack of safety and increasing homophobia in this country, right? So like, how do I wrestle with what's happening in my life now? And how do I start to take some steps towards feeling more safe and less overwhelmed? It's meant to be one issue at a time. It's meant to be collaborative. You know, the participant drives, like what's bothering me now and what do I want to work on? And as I mentioned, it's not about kind of solving all problems, but it's about gaining some skills to start to feel a sense of control, start to feel empowered, and start to feel like I can create this new normal and cope more effectively. Next slide, please. So these are the 7 steps of the model. And it's about, you know, first doing a better job of kind of clarifying and defining what is the problem in my life. And I should say the word problem is not a word that everybody loves. So you can use whatever word matters to you, the issue, the thing, the stuff. And the reason that first step is honestly the most important step is often when we define a problem, we define it so broadly, like I'm lonely or I'm tired, right? And that can make it feel really hard to even tackle because loneliness looks really different for different people, right? For some people, loneliness is having a lack of an intimate companion. For other people, loneliness is feeling like I don't have somebody to do kind of fun social things with now that my body has changed and it's harder to leave my apartment. So when we can define it more specifically, we can actually tackle it more effectively. Step 2 is setting a realistic goal. You know, this is all about kind of being smart, right? Being specific, measurable, actionable, time bound. You know, we often set goals that are quite big, which then makes it really hard to kind of even take a step forward. Step 3 is generating multiple solutions. So instead of kind of picking the first thing comes to our mind, which may be the hardest, quite frankly, it's about coming up with different ways I could tackle the problem. And then in step 4, kind of weighing the pros and cons of those solutions so that we can really kind of be thoughtful and realistic about what are some of the potential barriers, but what are some of the ways that this might actually work for me. So then in step 5, you're selecting something that's more feasible because you've weighed the pros and cons, you've thought about your goal, you've better defined the problem. Step 6 is kind of being really thoughtful and specific about the who, when, where, why of action planning to carry out that solution. And then at your next visit or session, you kind of ask how to go, what worked well, what can I amplify and feel proud of, what did I run into, and how do I kind of tackle some of those barriers going forward. Next slide, please. I want to share a little bit too about what behavioral activation is. And part of the reason we're going into specifics, and I realize this is a quick overview, is so you can be thinking about, okay, are these tools that we can be using in our setting for our community when folks are coming in and feeling disconnected and depressed? So as I mentioned, behavioral activation is really this idea of when we're depressed, we stop doing things that make us feel good. And then it becomes a cycle where we're kind of doing less and feeling worse. Behavioral activation tries to break that. So it tries to say, how can I do more as a way to feel better rather than sort of waiting to feel better? So doing things even if we don't feel like it. And this is often people think, oh, I'm just going to wait. I'm going to wait until I have more energy. I'm going to wait until I'm feeling kind of more confident. And this is kind of flipping it on its head, this more kind of outside-in approach. I'm going to kind of think about what it is I want to do. I'm going to take some steps to do it. And in doing it, I'm going to realize, hey, that wasn't so bad. And actually, you know, I'm feeling actually a little bit better because of connecting with my friend, picking up the phone, making that phone call. Next slide. So behavioral activation is pretty intentional about what types of activities are planned. And that's because these activities are all have been shown in research and practice to really function as antidepressants. So social activities are connecting with others. Physical activities are moving our body, and then this idea of pleasant activities. You know, what are these things that bring us joy? These activities do not have to be these kind of costly big activities. They can be really small, simple things. I mean, when I sit down for dinner tonight, I'm gonna light a candle, or I'm gonna cut a flower from, you know, outside my apartment building, so I feel just like a little bit more in this kind of beautiful space. We with Pearls have this handout with lots of different activities that folks have generated over the years, because sometimes people are feeling stuck, but we're really leaning on the person and having them drive, you know, what activity would matter to me. And then using actually some of those problem-solving techniques when folks run into barriers when they're planning activities. So really kind of integrating the two together to support each other. Next slide. So I want to talk a little bit about lessons learned from our Pearls research and practice, and Bradley too is going to chime in and talk a little bit about, share some really specific stories that I think kind of give meaning to the program. Next slide. I'm going to organize this learnings around a model called REAIM, and we use this model a lot, and I think it's a great model for folks out in the field doing evaluation and planning work, because it's not just about does something work, is it effective, which is what we often think about when we think about starting a new program and whether I'm gonna do a program in my community. It's looking at things like reach, who is the program reaching and who is it not reaching? How do I need to be more strategic and thoughtful about who we're partnering with? It's about things like adoption. So kind of who is the program reaching on a provider level, on an organization level, on scale. It's about how's the program being implemented and delivered and what can we learn and how to support doing that well. And then it's about how do I keep this program going? If I'm going to adopt this new tool or do this new thing, how do I make sure it's sustained? Next slide, please. So this next slide first talks about kind of what we've learned. We've been doing Pearls for about 20 years. What have we learned about who Pearls has reached? And really, increasingly, our focus is about reaching older adults who are facing inequities in access to mental health care. And I want to call out the fact that, many of the identities living here, listed here around people of color, LGBTQ+, people with multiple chronic conditions, there's a lot of intersection here. So people living, who are multiply marginalized by the fact that they're aging with HIV. And so part of the beauty of Pearls is that because it's person-centered, it's about tackling things that may be creating stresses and keeping those depressive symptoms going. I do want to say that we do not traditionally and historically do this program with people living with more severe cognitive impairment. I appreciated James' comment about people living and aging with HIV as having higher risk of cognitive impairment. This model, because of the executive functioning and kind of memory, et cetera, required for doing problem solving and behavior activation, it's really, some people with mild cognitive impairment can be successful, but it's really not meant for people like living with dementia or Alzheimer's or things like that. Next slide, please. So people ask a lot about, evidence for whom, right? This is an evidence-based program. Was it developed in my community? And is it going to work for the communities I work with? And so we've really tried to partner over the years with organizations that particularly reach older communities of color and linguistically diverse communities who, quite frankly, have really poor access to care. There's not a lot of bilingual, bicultural mental health providers. There's some of that systemic issues that James talked about in terms of mistrust of the medical community. And so these are some of the communities that we've worked with over the years with Pearls. And so if you are interested in serving linguistically diverse communities and you want to get connected to programs after today's call, my contact information will be here. And Bradley's organization also does an amazing job serving communities of color with Pearls. And so we're happy to kind of connect and talk about some of the nuances, some of the adaptations and things like that. Next slide, please. So this shows a little bit about kind of where Pearls has been adopted. This map is slightly out of date. We just have a new program in New Mexico. I know we have some West Coast folks here on the line, but we've reached over 12,000, I see there's a typo there, 12,500 older adults over the years. This is probably an under number because we don't require people to give us data. We're researchers. I know we love data, but really it's about reaching people. And so periodically we ask folks to give us their numbers so we can demonstrate to the CDC the work we're doing and continue our funding. We've tried to reach lots of different types of organizations, many of whom I see on today's call. So different faith-based organizations, cultural organizations, housing, a lot of kind of low-income senior housing to meet people where they are. And some mental health, public health, and community health centers as well. We've tried to build capacity among lots of different providers to do this work. I hope you've seen yourself in this work, and during the Q&A, happy to kind of talk about that. But really, any provider who has that trust and rapport and access with people aging with HIV, peer support specialists, case managers, community health workers, et cetera. We're also doing some work outside the United States, really try to increase access to care. And there's a lot of awesome global to local learnings that we're having too with some of the projects we're doing right now in Peru and Cambodia and Rwanda. Next slide, please. I'm going to turn over to Bradley to talk a little bit about lessons learned staffing Pearls.
All right, thank you, Leslie. Just to give a little bit of historical context on how Pearls came to us at Neighborhood House, it was actually introduced to us by the city of Seattle, by their Pearls coach. And Neighborhood House was to be a translator for their non-English speakers. However, we found that with the different cultural stigmas of mental health and having a third party in the mix, there was a big disconnection between the client and the Pearls coach because there was no rapport or trust built. But it was a good thing to note that people who did have limited English were really responsive to the Pearls model of it not being in a clinical or facility setting, and concentrating more on the problem-solving theory and change behavior to focus on what brings an individual joy, and partnering it with our funding. Again, we serve people who are living in poverty, immigrants, and refugees. With that, our VSHSL funding helps support us in paying for the training, as well as paying for some of the supplies or needs that our clients may need. One of our overarching programs that we have here is our unpaid caregiver program. In this program, we help with case management and resource navigation with our clients. With that being said, these are the clients that we offer Pearls to. With care receivers and caregivers, their biggest concern is burnout. So how do we help them when respite for our caregivers or care receivers is unavailable? How do we help them lift that burden of their everyday life? It is through Pearls that they are able to rediscover that they are their own person and their joy is determined through what they think, feel, and do. Giving them the tools on how to rethink the way they can live their lives. Within Neighborhood House, we have 9 full-time care coordinators or case managers who are either bilingual in Khmer, Russian, Ukrainian, Spanish, Vietnamese, Marshallese, English, Amharic, Tigrinya, and actually left out Somali on here as well. The benefits to the providers and staff with offering Pearls to our clients is professional development for our staff, less burnout for actually all parties, right? We have our clinical supervisor, Dr. Snowden, that we reach out to with any questions, concerns, anything like that. And so if needed, he'll redirect us to say, hey, I would recommend that your client needs to speak with another provider. So that helps lessen the burden for some doctors that are out there. And job satisfaction and overcoming cultural stigma by offering Pearls to our clients who don't have a good understanding of what mental health is, or have, again, that stigma against it. But by doing Pearls with them, they're able to see that, hey, mental health is not as bad as I thought it was, and I am more inclined to go speak with a doctor in regards to any of the conditions that they may have. Next slide. Perfect.
Thanks, Bradley. And I really appreciate you calling out the benefits to your team, because I think particularly with COVID, the social service workforce has just faced a huge amount of stress and turnover and just exhaustion. And so even though the work is focused on older adults and who are really struggling with being disconnected and depressed, like just hearing about how this work has supported staff it is really inspiring and exciting. And I think it's an area where we're continuing to partner on to support the workforce. Yeah. So I do want to talk a little bit about kind of how we know and what we know about Pearls working. This is kind of what drove us to partner with organizations like Bradley's to disseminate the model. So this is work done almost 20 years ago with older adults here in the King County area. And the slide kind of speaks for itself. The idea was people who did pearls compared to people who were doing whatever else they were doing for depression. That can mean nothing, that can mean medications, that can mean therapy. Pearls participants were 3 times as likely to improve their depression. And so this is really why we said, let's try to partner with organizations and do this model more. You may see your clients in this, in the numbers on the left, the demographics. So 42% of clients that we partnered with identify as a person of color. Most were living alone. Many were low income. I would say all were limited access to resources, but in terms of the definition by the social service organizations. And people are living with multiple chronic conditions, which I want to call out because as we think about HIV as a chronic condition, I know many of the folks you work with are living with other chronic health issues like diabetes, hypertension, asthma, etc. Next slide, please. These are some of the other outcomes we've seen from pearls: better quality of life, lower suicidal thoughts or ideation, reduced hospitalizations and nursing home stays. This is really important because people aging with HIV want to age in place. We've also recently done some research around social connectedness, and people who've done pearls have reduced their kind of sense of or perceived isolation and loneliness, as well as been able to increase the interactions they have and satisfaction with the social support they have. So not necessarily new connections, but just better connections. We also see people getting connected to social care, which is not all that surprising given that the model's embedded within social service settings. Next slide.
All right, so I'm going to go ahead and discuss one of the clients that we were assisting in our Pearls program. And right on screen is a chart of actually a tracker of their PHQ-9 over the span of when we were with this client. The client is 75 years old, male, and speaks Spanish, and only Spanish. His pre-existing conditions are HIV, diabetes, neuropathic nerve issues, feet numbness. And then with that being said, his overall, when working with him, his overall problem was as his body started to fail him, he started to get more discouraged and feeling more down because a lot of the things that he could do before, he now had to rely on his caregiver to take care of. This feeling grew as he saw his caregiver getting more and more tired and doing the work without any complaints. As a result, he started to alienate himself from the things he loved to do, thinking that he didn't want to put more pressure on his caregiver to follow along and clean up after him, adding more work to them. If you look at the chart, his beginning PHQ-9 score it has a high response. Working with our clinical supervisor or our consulting psychiatrist, Dr. Snowden from the UW, we were able to conclude that the sleep disturbance, tired, loss of energy, appetite, weight change was all resulting in his pre-existing conditions or his in conjunction with his medication. With Pearls, you can see throughout all of the sessions together, his score started to lessen. His loss of interest of pleasure, his score started to go down. Feeling down in blue, again, started to go down. Feeling bad about himself, again, started to go down. Even through the scores that we thought would remain the same, started to decrease with all of the activities and physical activities, social activities that they were undergoing. We could see that they were able to, their appetite did change, and they were actually starting to have more energy. Next slide, please. Oh, it's missing one. Sorry, is there a previous slide before this? There we go. Nope, it's still the same one. Oh, well, I just wanted to go over, it's not on the slide, but through all of the problem solving, the physical activity plan, the social activity plan, and the pleasant event planning, his baseline started to decrease because of the things that we were able to come up with, or he was able to come up with. He he described himself as a very social person before, but again, he's started to isolate himself. One of the things that he did enjoy was Bible study, and so figured out why he didn't want to go, and it was that feeling of shame. So he decided to take the first step, go to Bible study, and towards the end, it started to grow where he was able to now be the person that everyone went to help introduce and help be a part of the community for new members joining the congregation. Before he used to, when asked what is your pleasant activity that you enjoy every day, to me, when I heard this, it was kind of sad. He said, I don't watch TV. I just sit there on the couch and I just wait for one of my family members to give me a call. And so just sitting there waiting the entire day was his pleasant event of the day. So to increase that, we found out that he was a creative person. He enjoyed cooking, he enjoyed painting, he also enjoyed woodcraft. With that, we introduced, with our funding, we were able to purchase an Instapot. We were able to purchase also some paint supplies for him. So that started to get him on the ball moving on him being more active. With the Instapot, he was able to cook again, which he loves doing, but he doesn't have to stand around the stove all day. So he just pops it in and cooks the meal all in the comfort of sitting down, and he enjoys that his caregiver is able to eat the food that he cooks. That also helped increase his appetite later down the road because he started to research what are healthy meals, like what should I be eating, what will help my diabetes, right? What will help give me energy? And one of the physical activities that we started to do was, at first he was complaining about his feet hurting. He didn't have the energy to go on walks. He couldn't walk for a long time. So, and options were given such as breath work or yoga, and he really enjoyed yoga. So actually, he started to do yoga every day, and later he was able to join a senior yoga group where, again, he was able to socialize with more people and still be active. Yes, next slide. Thank you.
Thanks for sharing, Bradley. I really appreciate you humanizing, how this model can support people. But really, I feel like it illustrates how just often when people are depressed, they get stuck, and without kind of realizing it, they're doing the same thing routinely. That's sort of not helping them live a healthier, happier life. So I just appreciate whether the Instant Pot so you can sit, or a new way of moving your body, and how the coach worked with them. So the next slides that we're going to wrap up with are just really kind of a little bit about kind of how you do pearls and how we can support you in case after today that's something you're interested in. So our center has been nurturing a community of practice, and we've got lots of tools around training and support. We're also always trying to think about how do we adapt and kind of make the model work better for different communities. And so one of the projects we did in partnership with Neighborhood House and other organizations serving older Asian communities is talk about, how can we adapt the model, meet people where they are, not just culturally, but also the realities of these organizations, small organizations doing lots of different programs and integrating pearls into what they do. Next slide, please. So for folks who manage programs, we kind of bake in quality assurance to the pearls model, not just with training, but the use of the PHQ-9, the use of these structured interventions, problem solving and behavioral activation. Bradley talked about how they have their clinical supervisor to support, and we also have ways to manage data. What we've really found is that adapting the model with for and in communities that have been historically underserved is an implementation strategy for how we basically promote health equity. This is how we improve access to care and ultimately people's health and well-being. Next slide, please. So we want to give a little bit of examples of how we've done that adaptation work. So as we talked about, culturally, we've tried to really think about, how do we align with different norms and beliefs, not just language, to meet people where they are and how they think about care. Operationally, we've really tried to think about kind of where we do the work. So COVID bumped everything to distance, not just delivering, but also training. We also tried to really be thoughtful about expanding eligibility to meet people where they are. There's such a lack of services for older adults. And then we tried to look at different outcomes, not just depression, but how does the model help with social connectedness? How does it help with aging in place? Bradley's going to talk a little bit about how they've partnered with community, I think, to adapt Pearls next.
So with our community, we first started off with working with caregivers and care receivers. Actually, because there was such a huge increase in the year 2023 of clients wanting to do Pearls, we are expanding it to be towards anyone that would like to join at 55 and older. So it's not only now to our caregivers or care receivers, now it's to anyone that fits the eligibility of 55 plus and is suffering from like depression. The other adaptation that we did to make it more culturally appropriate, of course, was translation interpretation differences. With Pearls, we do have the worksheets to go through. However, with translation and interpretation, the meaning is something different. So Pearls is not so definitive in saying you have to do this, or you have to do it this way, 1, 2, 3, 4, 5. But we're able to rephrase questions, but still have the same efficacy of the question. And said, of course, in a different way. Another adaptation that we had was we have funding to help with additional purchases for the items that makes it more culturally appropriate, or items that are that would benefit their health and well-being. And finally, assisting not only with mental health, because our care coordinators also assist with resource navigation. It helps relieve some of the stressors that the client is feeling, saying, hey, I'm feeling stressed because I can't find a house or another home, right? So we try to take that off of their plate and focus more on the here and now and themselves, right? So focus on the things that you can do. As far as housing, let me find some different options or find something for you, and then I'll present it to you at a later date. And so that helps relieve some of those stressors there.
Thanks, Bradley. Next slide, please. I think the other piece we wanted to highlight is just how the model Pearls can align with what we know about doing cultural adaptations well. So because it's person-centered, it aligns with how we talk about depression using cultural beliefs and norms, language. The D word is not something people always want to talk about. They use other words to describe their symptoms, and we try to follow their lead while also educating and empowering about what depression is with the course of the program. Bradley, I think, gave some great examples of how they've tried to adapt the model to serve linguistically diverse communities of color, and really training staff from the community who are trusted and partnering with those trusted organizations to engage people in the program. Next slide, please. I think the last things we'll talk about here are around costs and funding, and then we'll open up for questions. So, costs are going to vary by organization because the main cost is really the cost of doing the work. So whoever you have at your organization do outreach and screening, participate in the clinical supervision, which is usually an hour or so a month, and then do Pearls. So if it's integrated and you have staff who do it all part-time, it's not a new salary, but if you're hiring folks, clearly that has to be covered. We do have a one-time payment for training. It's $500 per person, and then there's no kind of additional fees, and we provide support as an organization with our funding from CDC. The next slide is going to show some different funding options. I know people are from all over the Western coast, so some are very state specific, but it's a lot of different types of money out there, both to support older adults as well as mental health. So in California, the Mental Health Services Act, different people are using Medicaid and Medicare. There's older American specific money from the feds. Some people are using nonprofit hospital community benefits, but happy to brainstorm about funding during the Q&A. Next slide, please. I think I'm going to have Bradley share about a little bit about how they funded the work, and then I think we'll skip to the last slide, JB, after this, and just open up for questions. So I want to be respectful of everyone's time.
Yeah, so there are two grants that we work with here in King County. The first one is the Veteran Senior and Human Services Levy. That one helps fund actually a lot of the training materials that we do have, and also funds the materials that we purchase for our clients. Also, Community Living Connections, City of Seattle and King County. This helps us do our outreach for the program. So this helps pay for the staff that do the outreach, goes out to find the clients and things like that. Because we are expanding Pearls to a wider demographic, we have put out two grants that I'm happy to say that we did get, but they are, one was through SAMHSA, and then the other is through a it's also through the county. And they're focusing more on mental health. So just look out there for anything that is mental health, or anything that could assist the aging and disability population.
Thanks, Bradley. So JB, I think let's skip ahead to the slide that's like in summary. We can talk about other Pearls research opportunities during the Q&A. This one, perfect. So just to wrap up, hopefully it's helpful to hear kind of one model that provides more structure and tools for identifying people who might be struggling with depression and disconnect, providing some skill building using brief skills like problem solving and behavioral activation, seeing a little bit about what capacity building we can provide in terms of supporting your organization, and then really just how are you going to integrate care into services that you already offer that are reaching older adults aging with HIV who've been systemically excluded from mental health care. So look forward to the discussion and the breakouts, and happy to chat. The last slide has both Bradley and my contact information. Thank you, Bradley, for your partnership in this, and we'll open it up for questions. Back to you, JB.
Thank you. Thank you so much for that very insightful presentation on Pearls and how you've adapted it at Neighborhood House to like serve such a diverse population, and how we can also how we can tap into the Pearls services as well. And related to that, Greg dropped a question in the chat. Is there a way to find local organizations that offer Pearls programming?
Yeah, thank you, Greg. We don't have like a locator. We used to have one, but it was hard to keep up to date with the ever-changing COVID climate. But I have a list. I'm happy to share it with JB, or I'm going to put in the chat the email to reach out to the Pearls team, and we can connect.
Thank you. Are there any other questions for the Pearls team around like how they implemented it, who it's for, opportunities to collaborate, and specifically, at least like something that I heard was that this can be really adapted no matter where you are. And I know there's more resources to tap into the Pearls learning, the trainings and the different models, but does anyone have any questions for the team themselves? I see Richard, your hand's raised. Go ahead.
Yes, my name is Richard. I'm from Sacramento. I'm also Hispanic. I think one of the biggest challenges for our BIPOC community is from a cultural as well as a religious perspective. Kind of it's taboo if you're seeking mental health support. The preferred guidance within these cultures is to seek spiritual and or religious guidance. I'm curious from an outreach perspective, what have been some of your successful methods of overcoming this particular stigma? And what are some of the barriers and challenges that you've encountered? I know it's not as prevalent on the West Coast, but I'm from Texas, and I can relate to Sean's comment that outside of our area, the story and the picture is much different in the rest of the country. So if you could just kind of elaborate a little bit on that.
Yeah, great question, Richard. Thank you. So it's all about partnering with folks that the community trusts. So in the Hispanic or Latino community, I think where we've had successes is actually in some faith communities where it's engaging pastors or other spiritual leaders to really help, kind of normalize depression and disconnect, that it's not that you're loco and it's not a normal part of aging with HIV or other chronic conditions. It's a real thing. It's caused by when things kind of pile up, and there's something you can do about it. So I think that's really helped, and making that kind of one-on-one connection to a program. So like maybe even training people from the faith community to be Pearls coaches, though there's also some privacy realities. So that's kind of been hit or miss. In some places, people really kind of don't want to know the person, right, who's providing their care. In others, that can be exactly actually what they need, is seeing that familiar face from church. I think the where it's been challenging, I think with communities that have a real strong sort of faith in that kind of it's up to God or whoever I believe in to kind of solve this. Like this whole idea of empowering myself to take control of my life, like doesn't resonate culturally. The way we've tried to kind of frame or describe doing things like problem solving and behavior activation is that this is something that can be done kind of like in complement with your faith, so in addition to going to Bible study, in addition to praying when you're feeling down, what are these other things that you might do while you're praying? Or maybe where you're praying is you're doing it in community instead of on your own, for example. So it's like being really intentional and thoughtful about you don't have to not have your faith basically to do problem solving. It's like, how do I do problem solving to augment my faith, and sort of help God help me, I guess, is kind of how people have described it. Bradley, I'm curious if you have other insights, both in terms of
yeah, that was the second one was exactly it for us again. Actually 100% of our clients are non-English speakers. And I would have to say 100% of them for their social activity will say that going to church is their, or praying is their number one social activity that they would like to do. The thing about Pearls is, and again, it's about that whole linguistic adaptation. We are not clinicians, so we're not here to make any diagnosis. We don't say that you have depression. We're really here, that's for a clinician to do. We're really here to talk it out and have them go through the program, and we describe the program again in different words, but we're describing the program on how we can help you help yourself, basically. So it's we don't use that the D word like Leslie said. Again, we use other words to help them understand the situation they're in and how they can take the steps to better themselves.
Thank you.
Yeah.
Thank you so much for that insight, Leslie and Bradley. Like what I really got out of it is like really focusing on what creates joy for that specific person, and to help like really tap into those activities and to identify those and support them in the ways that we can. So I appreciate that insights of how Pearls and like the different components of it, such as behavior activation and problem solving can be applied to a wide range of audiences. Do you have any questions before we go into the breakouts for the Pearls team, for the psychiatry team over at the University of Washington as well. And while we contemplate, I'm going to pull up our poll here, because we do have a little bit of time for a breakout session, just to address the different kinds of mental health considerations and needs for older adults living with HIV. So I'm launching a poll here on which breakout room would you like to join. We have 3 different options. We have the clinical case discussion. How do you currently talk about mental health discussion, and what concerns do you have talking about mental health discussion? Your choice for this breakout will then determine which breakout room you're going to be assigned to. So go ahead and take a second to think about these 3 options, and then we'll have our speakers and myself facilitate the different breakout rooms. But I also want to take a moment to congratulate and thank our speakers as well for giving such great information about the various mental health needs of people aging with HIV and how we can all better support our clients and each other.